Now, Richard, so again, you're in this huge market here in Chicago. Again, lots of medical centers. Your group's set up a little bit differently. You've got, what, 68 docs now, and how have you guys done this? Because I know you brought this in-house now.
Yeah, we've been going for about 2 months. We have a center that we do them in. We have a couple of champions, which I think is very important. I think it's a kind of technology that is fairly complex, and you really want to have people who know what they're doing. You want to get good results. So we have a couple of champions who are embracing this technology, and we have referrals into them, and they're the ones that are doing the biopsies. So far, we've had about a 60% plus positive biopsy, as opposed to our rate of about 40% for just random biopsies. And I think that's the key. I think what we're really going from with traditional prostate biopsies is this concept of going from a random to something that now is more specific and more directed. And we're trying to hone down and be more accurate and be able to get better results with, for better, as I keep saying, better patient care, and also with hopefully less morbidity and toxicity.
So what patients are you currently offering this technology? Is it for everybody that gets the first-time biopsy? Is it people with prior negative biopsies? What is your protocol?
I don't think that anybody can really just jump into this for your first random biopsy. I think most insurance companies, first of all, won't even pay for it. I think many of them you have to have at least 1 and maybe 2 negative biopsies before they're going to pay for it. So I think, at least in our group, our parameters are that you have to have at least 1 negative biopsy and, you know, a strong suspicion that you have prostate cancer. In the past, we've been doing pretty much saturation biopsies, template guided, which have kind of been the standard. And we were probably about 50% there in picking up positive prostate cancer. So saturation biopsies are performed under an anesthetic. The multiparametric biopsies are not. We're doing them without anesthesia, so I think that's an improvement for the patient as far as less toxicity. And I think that we do have a higher yield that we're seeing even over our saturation biopsies. So again, I think it is an advancement. I think there's still a lot to be learned from it, the false negative rate, but I do think that in situations where you're kind of on the borderline, do I want to biopsy somebody again, and you send them for an MRI and it comes back negative, you have a little more confidence and a little more ability to say, you know, let's just watch this and perhaps repeat your PSA and come back again in, you know, 4 to 6 months and we'll look at it again.
Okay. So Gary, you and I were having this discussion coming over here today. So you're in Cincinnati. You've got, what, 30 guys now?
Closer to 40.
Closer to 40. You've got a great setup in that you've got a unbelievable, beautiful facility that sits right there in Cincinnati. You are probably you know, one of the most successful medical CEOs for big urology groups. The president-elect of LUGPA. Tell me about how Cincinnati is going to look at this, how you're going to incorporate it from the clinical side, but also from the business aspect.
Well, thank you, Raul, and I will tell you that we're struggling with it. I agree with everything that's been said here, Neil. This is a disruptive technology that we absolutely must embrace. We can't stop progress. This is important for patients, and we must embrace it. Now, having said that, I see 2 operational challenges with it. One is the economic challenge, because although we must do what's right for patients, also at the end of the day, we have an obligation to stay in business, and we can't really invest heavily in this for the future without reimbursement for it. It's a roadblock. The second problem I have with it is, and I think this was alluded to, is who do we biopsy using this technology? And I think everyone agrees today that it's for the patients at very high risk, as has been explained by Richard and Sandy and so forth. But I imagine a day not too far off where the educated patient comes in for their first biopsy, and they say, I understand you have this great technology. How come I don't get that technology and the other guy who's had 2 or 3 negative biopsies does get that technology? I want it up front. And then I see an operational challenge. We do 2,500 prostate biopsies a year. I see an operational challenge of being unable to offer this technology operationally to 2,500 patients on day 1. So those are things that I'm struggling with, Raul, and I'm hoping that through some clinical protocols and science that will be developed, we'll have a better understanding of really where this is appropriate.
No, I think those are great points because, Sandy, you and I have talked about this, is that to some degree, by incorporating this under the current reimbursement strategy and coding, you're a little bit of a loss leader. You get a little bit of an advantage by doing them in a surgery center where you obviously capture a facility fee. But if you're not doing them in the surgery center and you're doing them in an outpatient setting where there is no facility fee, I think with the current coding you capture maybe an extra $100. It takes longer, but again, as we all I think agree upon, that it clearly does represent a big step forward in terms of diagnosis and potentially trying to figure out who does really need a biopsy, and more importantly, who as we embrace active surveillance with the use of what these images show, may be more appropriate candidates, maybe less appropriate candidates. There's still a lot of questions. Sandy, I know you wanted to follow up on a piece.
Well, I instinctively believe that this will ultimately lead to better care, more proper diagnosis, more proper treatment, and I think we've been under a lot of pressure to do less biopsies and treat less prostate cancer. And I think this is one of the ways that we may be able to get there. Along with biomarkers and all the things we do, we will be able to get there, but it's going to take time.
Yeah. And again, I think there's lots of questions, and I think as this rolls out, hopefully into the larger groups like all of ours, we can actually have collaborative efforts working with industry and working with our academic partners to answer some very key questions, as long as we're all sort of doing the same thing, trying to look at the same patients. I agree, though, Gary, that we are going to see a lot of walk-in business. Part of that will be driven, it'll be definitely consumer driven as the word leaks out from articles in the Wall Street Journal, everything else, that people, especially the savvy patient, the savvy consumer, wants to look at this and has a complete understanding about what the current downside is of traditional biopsies.
Hey, Raul, can I just make a comment?
Absolutely.
So this is such a great discussion and can go into much greater detail. So tomorrow at our annual meeting for LUGPA, we're going to have a 5-hour CME accredited course in prognostics and diagnostics in GU oncology, and one of the lead-off presentations will be Samir Taneja, who's featured nicely in this Wall Street Journal article you've alluded to. And he will be reviewing multiparametric MRI, and then you're going to be the discussant for the end of his presentation, as well as Brett Lowentritt from Sandy's group, who's had tremendous experience with this as well. So I would just say for